Hello everybody and welcome back to lecture. Today we're shifting from accountability and punishment to a different philosophy of drug policy altogether. Harm reduction. Harm reduction asks a provocative question. What if the goal of drug policy wasn't to eliminate drug use, but rather to reduce harm to individuals and their communities? This approach has gained momentum globally, and more recently in certain U.S. cities and public health systems. But it remains controversial in nature, especially in states where drug policy is heavily criminalized. Today, we're going to cover what harm reduction is and what it isn't, core principles and examples of harm reduction in practice, arguments for and against harm reduction policies, and how harm reduction fits or clashes with traditional enforcement approaches. Let's go ahead and get ourselves started. Harm reduction refers to a set of public health strategies that are designed to reduce the negative consequences of drug use without necessarily requiring abstinence. Some well-known harm reduction tools include syringe exchange programs to prevent the spread of HIV and hepatitis, fentanyl test strips to reduce overdose risk, naloxone or Narcan distribution to reverse opioid overdoses, and supervised consumption sites in some countries where users can take drugs under medical supervision. At its core, harm reduction is rooted in pragmatism. It accepts that some people will use drugs, and it asks, how can we reduce death, disease, and social disruption while preserving individual dignity? Importantly, harm reduction doesn't condone drug use. It recognizes, though, that drug use is a part of our world, and it aims to minimize harm rather than to moralize behavior. Harm reduction challenges the dominant U.S. framework of criminalization in three big ways. First, it centers individual health over public morality. Instead of viewing users as criminals, harm reduction views them as people in need of support, stability, and safety. Secondly, it treats drug use as a health issue, not as a moral failure. The goal here isn't to judge, it's to prevent overdoses, infections, and break down the lives of individuals and their communities. Three, it is very community driven. Many harm reduction programs are led by grassroots organizations or peer-led networks, not by state agencies. This makes harm reduction both radical and both deeply practical at the same time. It's less about changing individual behavior and more about reducing death, illness, and systemic burden, especially for people who may not be ready or even able to quit yet. Let's walk through a few real-world harm reduction policies and programs. We'll begin with syringe service programs. These are legal in some states and banned in others. These programs help to reduce the spread of HIV and hepatitis by providing sterile syringes, safe disposal sites, and often referrals to treatment and housing programs. SSPs also have been shown to reduce needle litter and increase public safety. Next, naloxone or Narcan distribution. In some states, it now allows pharmacists to dispense naloxone without a prescription. Community programs hand it out to users, families, and first responders. Research shows that widespread Narcan access saves lives, especially when paired with education on how to use it. We also have fentanyl test strips, which are low-cost tools that let users test their drugs for fentanyl contamination. While still criminalized in some states and seen as drug paraphernalia, they've become a frontline defense in reducing accidental overdose. We also have supervised consumption sites that are still in the pilot program phase in many countries, like Canada, the Netherlands, and Portugal, which all have supervised sites that allow users to inject drugs with clean supplies in medically supervised environments. These are very controversial, but no overdose deaths have been recorded in any of these sites. Some U.S. cities like New York have launched pilot programs despite federal pushback. Now let's take a little bit of a closer look at one of the most powerful tools in our harm reduction arsenal today. Narcan, also known by its generic name, naloxone. Narcan is an opioid antagonist, meaning it's a medication that reverses the effects of an opioid overdose. It works by knocking opioids off the brain's receptors, allowing the person to breathe again. Beginning in 2023, Narcan has now been made available over the counter at most major pharmacies across the U.S., including CVS, Walgreens, and Walmart. No prescription is needed. This change is monumental. It makes overdose reversal tools more accessible, not just to the people who use drugs, but to families, teachers, community members, and even to college campuses like ours. The over-the-counter version typically comes in a single-dose nasal spray, easy to use with no prior medical training. So when should you administer Narcan? Narcan should be administered as soon as an opioid overdose is suspected. Common signs include unconsciousness or inability to wake the person up. They may have slow or regular or even stopped breathing. Their lips may be blue or gray or their fingernails can change color too. Their pupils might be pinpointed. You don't need to be sure that the person used opioids. If you are ever in doubt, administer Narcan. It won't harm someone who didn't use opioids, but it could save the life of someone who did. So how do you administer the nasal spray? Narcan comes in a 4 milligram nasal spray, and when you use it, first call 911 immediately. Tilt the person's head back and support their neck. Insert the nozzle into one nostril. Press the plunger firmly down to spray the entire dose. If there's no response in the first 2 to 3 minutes, administer a second dose if you have it available. Make sure to always stay with the person until emergency services arrive, and know that if they do wake up, they may wake up in a disoriented or distressed state. So why does this matter? Narcan is one of the very few tools that we have that can instantly save the life of a person in the event of an overdose. Its increasing accessibility is a major success story in harm reduction, but only if people know how to use it. Encouraging Narcan access isn't about enabling drug use. Again, it's about recognizing that dead people just don't recover. Reversing an overdose gives someone a second chance. Despite its life-saving potential, harm reduction remains one of the most divisive approaches in American drug policy, particularly in states like Texas. Let's break down the most common criticisms and why they persist. First, critics argue that it enables drug use. Critics argue that providing clean syringes, fentanyl test strips, or Narcan sends the message that drug use is acceptable or it is without consequences. But studies show that harm reduction does not increase drug use. In fact, many users who access harm reduction services are more likely to enter treatment later on. These programs often serve as a point of contact and one of trust, especially for individuals who are reluctant to engage with medical or other legal systems. Critics also argue that it wastes taxpayers' dollars. Some opponents view harm reduction as a misuse of public funds. But from a fiscal perspective, it's quite the opposite. Needle exchanges, Narcan programs, and overdose prevention save millions in emergency room costs, infectious disease treatment, and law enforcement response. A 2017 CDC study found that for every dollar spent on syringe services, at least $7 are saved in HIV prevention alone. Critics also argue that it undermines abstinence and recovery programs. Abstinence-based treatment programs sometimes reject harm reduction on philosophical grounds, claiming that it distracts the users from sobriety. But harm reduction and recovery are not mutually exclusive things. Harm reduction acknowledges that people use drugs for many complex reasons, and that survival is the first step towards healing. Many successful recovery journeys begin with harm reduction contacts. In terms of Texas, many harm reduction tools remain restricted or even criminalized. Syringe service programs are illegal statewide. Fentanyl test strips are classified as drug paraphernalia, although there are some legislative efforts that have been made to try to change this. Safe consumption sites are politically untouchable in this state. This reflects a broader commitment to punitive drug policy, even when data shows that the other approaches save lives. So now let's contrast this with other states and cities where harm reduction is not only allowed, but it is embraced as evidence-based public health strategy. In New York and Washington state, we see syringe access, where both states fund syringe exchange programs that have lowered HIV and hepatitis transmission rates. Both programs increased entry into treatment and showed reduced medical costs that are associated with skin infections and endocarditis. In Seattle, the Needle Exchange Program is now part of a broader public health hub that offers housing referrals and peer counseling to clients. In Rhode Island and Massachusetts, we see Narcan distribution. In Massachusetts, community health centers and libraries distribute Narcan with training opportunities. Overdose rates in participating communities have dropped by 25% or more. In Rhode Island, they're passing legislation that mandates Narcan kits in all public high schools and colleges. New York City also offers a pilot program for supervised consumption sites. New York opened the first officially sanctioned supervised consumption site in the U.S. in 2021. Within the first year, over 600 overdoses were reversed, emergency response costs dropped, and absolutely nobody died on site. Despite federal legal risk, local leaders have continued the pilot program based on its initial success. So why compare? These examples show that harm reduction is not theoretical, that it's working in real time. And where it's been implemented, we're seeing that overdoses are in decline, that healthcare burdens are dropping, and that public safety improves. In contrast, Texas continues to criminalize tools that are saving lives elsewhere. This isn't just a philosophical divide, it's a policy choice with measurable human consequences. Today, we explored harm reduction, a philosophy and policy model that treats drug use as a public health issue, not just as a criminal one. Today, you learn that harm reduction prioritizes survival, safety, and dignity, especially for those users at the highest risk. Common tools include syringe exchanges, Narcan, fentanyl test strips, and in some cities, supervised consumption sites. These strategies are often misunderstood or opposed, but where they're implemented, they save lives, they reduce costs, and they improve access to care. Meanwhile, in states like Texas, many harm reduction tools remain illegal, highlighting how drug policy varies sharply based on geography and ideology, even in the face of overwhelming evidence. In our next lecture, we'll zoom in on Narcan distribution, safe consumption infrastructure, and the emerging role of first responders, who are often the first and last line of defense in preventing overdose deaths. Thank you for staying with me today. I'll see you all next time.